Happy Wednesday, everybody. Thank you for waiting with us. Couple of minute delay. Sorry about that. We had literally last second technical difficulty with unmuting, so we had to fix that up for you. But thank you for staying with us and joining us for How to Encourage an Adventurous Eating Using Reinforcement-Based Strategies by Anissa Doyle. Anissa, thank you so much for doing this for us. And I want to thank of course, and thank each and every single one of you for joining us today. During the next hour, you're going to have the chance to earn 1 CEU, and the way that you'll earn that CEU is by staying the entire time. I know, such a long time you have to join us today. But also, you'll have to answer a couple of poll questions that are going to be popping up on your screen. So I hope that you guys all joined with that join webinar button that was emailed out to you yesterday, earlier today, a week ago, depending on when you signed up. It was could have been emailed to you all 3 times. But anyways, so within that button, it gives a unique link linking to your name and email. So this way it's unique to you. If you are dialed in audio only, then GoToWebinar cannot record your attendance whatsoever. So we don't know that you're here, and I cannot grant you any kind of certificate, whether that's a general certificate of attendance or a CE certificate. So even if you have technical difficulties, please make sure that you do join with that join webinar button that was emailed to you, even if you have to call alongside. Alrighty. If you have any questions, go ahead and throw them into the questions box. I'll answer the ones that I can. Otherwise, we will have some time for Q&A later on today. What else? All right. I'm going to go into a little bit more detail about your certificates when the first poll comes up. So just keep that in mind. But otherwise, I think that's all I have to say for now. I'm going to turn it over to Anissa.
Thank you so much, and I appreciate everyone that came here today to talk all about selective eating and how can we increase food acceptance. I'm sure many of us who are working clinically, or even if you're a parent, have had struggles with this. And what the basis of this presentation is really centered around is, first of all, ethics. I think for many of us in this field, anytime we start even considering food programs, ethical considerations are absolutely top of mind. So we're going to talk about that. And we are also going to talk about what other fields do and also some ways to increase generalization with the support of parents. All right, so a little introduction about myself, Anissa Doyle. I have my PhD in general psychology. I'm an associate professor at Capella University. I am an inventor. I actually have developed a food program product called Ate the Plate. But I will say that since the completion of my PhD, that product very much has taken a backseat. However, I still very much have an interest in food programs and how can we make meal times a reinforcing time for our clients and not so aversive. I'm a behavioral scientist consultant. I do a lot of work with tech companies and try to support their development with a UX viewpoint and also looking at it through a behavioral lens, and a gamification specialist. My research for my dissertation really centered around gamification and engagement. So that's just a little bit about myself. Now, before we get too deep, I do want to talk about the ethics codes. So first and foremost, anytime that you are considering any type of food program for your clients, I think it's first important to note Ethic Codes 1.05, practicing within scope of competence. So if this is something that's new to you, or maybe you've not had much experience in the past, it is an ethical consideration for you to seek training, to find a mentor, to find someone to maybe co-create treatment plans, just to make sure that what you're developing is in alignment with your scope of competence. Something else to consider is medical needs. There may be times where if you have a client that has food selectivity, it may be due to an a medical need. So making sure we're ruling out any type of medical concerns, and if that medical professional has given that stamp of approval, all is well, then we as behavior analysts could potentially implement behavior plans that are within our scope of competence. And then lastly, we need to prioritize positive reinforcement procedures. So often, at least in my experience early on, there was a lot of escape extinction around food programs, which of course we know that is a punishment-based procedure. So we really need to focus first on reinforcement procedures, especially when it comes to food programs. So here's the learning objectives for today. We're going to be exploring food selectivity and review empirical evidence from other fields. So again, going back to our competency here, as a behavior analyst, I am not an expert in nutrition or occupational therapy. That's just not our scope of practice. However, I think it's important to review their literature. I definitely reached out to OTs and nutritionists and say, hey, what are your best practices? What are some of the literature saying about food programs and changing these behaviors? So I want to share with you a little bit of those research-backed strategies, and then we're going to kind of tie it back to what we know as behavior analysis and some of our strategies that we implement. We're also going to review empirical evidence on reinforcement-based procedures in behavior analytic literature that shows improvement to food acceptance, and then lastly, reviewing parent training. So there's actually a ton of information here, but I also think this last part of reviewing parent training is so important. I always say we can have a perfect intervention, but if we don't have the support at home, then it's really hard for these skills to maintain. And so also with food, we're eating every day, all day, and our clients are not only going to be in clinic. Most of them do go home with their families and they have meals and they have to eat. So that's why it's so important that we also focus on parent training. And again, even if you're not a parent on here and you're a clinician, this is information that you can then take to your parents on your caseload. All right, so first discussion here, really if you can just kind of think about it as well, but just what are some of your current obstacles that you've identified with your current interventions that you're using for food programs? So you can put it in the question box or the chat box, but really just think, okay, where are my current barriers right now? Or maybe what do I hope to get more information on? So we'll just kind of take a couple minutes here to kind of connect with that. And again, my hope is the information that's being delivered today will then hopefully help you overcome some of these observed obstacles. All right, so I'm going to share some of my own experiences with food programs. So when I do consulting now, but when I was full-time clinical, I had several clients that needed food programs. And of course, we're implementing these programs using bite for bite paired with escape extinction. That was how I was trained. I then realized, wow, this is incredibly aversive for these clients. And we were sitting at this table for an hour for them just to have a small bite of food. Of course, this is now aversive for all of us. Not a great experience, in my opinion, was just continuing the target behavior there. So another thing, when I was teaching about food programs and negative reinforcement, of course, it's a reinforcement-based procedure, but the intervention was obviously considered aversive to some of the clients as well. So the child was accepting food to avoid a non-preferred food implementation with a nook brush. So again, I was reading all of this, I was experiencing it, and I was like, there has got to be another way to approach food programs that is more rooted in reinforcement-based procedures. Now, I also understand after you've exhausted all reinforcement-based procedures, there might be times where this negative reinforcement or even punishment procedures may be warranted, because again, food is something that we need to survive. But I think for all of us to at least begin, we really need to be focusing on these reinforcement-based procedures. But before we get into what other fields are doing or even what our own science says about food programs, I think it's important to operationally define selective eating. So from a parent's perspective, you have probably heard, or maybe even your own kids, maybe things like, my child won't try anything new. My child hardly eats anything, or any phrase that indicates a child with a limiting diet. So it's important to note that picky eaters is a broad continuum. There's not just one linear pathway when it comes to food acceptance. We're continuously kind of going back and forth with that. And there's not one classification system for selective eating or quote unquote picky eating. So let's talk about how common it is. So selective eating is a relatively common problem during childhood. Now, of course, there's varying sample size and results to this. Anywhere between 8 and 50% of the samples that were studied were identified as selective eating, with the operational definition of a child that is eating limited amounts of food, restricted intake, particularly of vegetables, and being unwilling to try new foods or have strong preferences. All right, so let's talk about it being a phase. We hear this all the time. Medical professionals all the time are like, oh, it's just a phase, they'll get over it. But what can we do about that, right? So food neophobia is when you're reluctant to try to eat new foods. And it is so common that it does present as a normal phase of development. And I always say, is it age typical or age appropriate? And I would say picky eating or selective eating is definitely an age typical behavior. However, one that would still warrant intervening on if it is hindering their development. So what do we do here? And why is it important? Why is this socially significant for us to address selective eating? So in one setting, 40% of the children who were irregular eaters at 5 continue to be irregular eaters at 14. So as we can see, as the younger they are, if intervention is not implemented, the chances are 40% that they will continue to be selective eaters up until teen and probably even beyond that. I mean, I know even myself, there are some foods where I'm like, I'm fine, I don't want to eat that. And that's fine, we all have preferences. But it becomes a concern when development is then hindered because there's not a well-balanced meal. All right, so we have our first ASR here. And so the question is, selective eating can be operationally defined as a child eating a limited food, restricting intake, and being unwilling to try new foods. True or false?
Perfect, everybody. Thank you. Go ahead and take some time to answer this. A blue box should have popped up on your screen, and you should be able to select an answer and submit it with a submit button. If you have any trouble with this interface at all, please do not put your answers in the questions box. Please put your answer in either a Word document or the body of an email, and you can send it to me after the webinar, and that will perfectly suffice for your participation. If you need CEUs, please make sure that you are participating in these poll questions, as they are a requirement. If you only need a certificate of attendance, then you do not necessarily need to participate in these to receive that. However, we do love to see that participation number go way, way up when you do. Alrighty, but let's shut this one down. And it looks like 95% say true and 5% say false.
All right, we should be back here, and the answer is true. So good work for all of those that answered that correctly. Okay, so now let's pivot to talk about the review of other fields. Again, I found this to be so important in my development of the product for food programs and even just the implementation of food programs. I needed to know, what are the other fields who are historically experts in food programs or food acceptance? What are they doing? And again, I consulted with OTs, I consulted with nutritionists. I was asking for any readings that they could give me because I wanted to learn more. And it was so humbling to talk with these other professionals. And of course, we know the science of behavior, but it's also so important to be open and willing to learn from other fields as well. But again, as behavior analysts, we are so tied to the literature. It was important for me to look at their research, but then see, okay, how can we adapt this, or what is being studied in our own science that would be applicable for us to use? So first of all, in the field of nutrition, they have a strategy called food chaining. Here's a picture of it, just an example, but it originates with an accepted food item. I know when I work with families, I all the time am like, okay, give me a list of the preferred foods, the home runs, the foods that you can always count that your child will eat. What are those? It's so important to understand where our baseline is and how we can continue to shape the food acceptance or even the food type. And so what happens with food chaining, it's created by making gradual changes to the accepted foods. And it works because you are strategically introducing new foods that they are going to eat. Now, You can see here, preferred food is peanut butter, then we're going to put it on bread, then add jelly and so forth until we get to the point where the individual is accepting cubed apples with peanut butter. I think it's also important to note that some of this progression is not going to happen overnight. We are going to go slow with this. We want this to be a positive experience for the clients, and we're not just going to go straight to cubed apples with peanut butter. But again, if you create a systematic step of shaping, essentially, then you will be a little bit closer to that terminal goal. So here's just more examples of food chaining. I have a client currently working with that they will only eat McDonald's chicken nuggets through the drive-through at 11 a.m. Like that extremely rigid when it comes to this food item. So one way to kind of progress through that is you might have your 11 o'clock McDonald's run, but instead of giving them the McDonald's, now you're going to give them a different new brand of nugget. Of course, we're just changing one variable at a time. And then we can continue to move through those steps, whatever those steps make the most sense for that client. Another example here, goldfish. I mean, like who doesn't love goldfish? Love a good goldfish. But again, it kind of lacks some of that nutritional value. And so we are finding ways to slowly and systematically introduce new foods that are in alignment with what they're currently accepting, whatever their baseline is. We're trying to meet them where they're at. And then we can continually shape what that next food item is. So of course, nutrition calls it food chaining. I see this very much as shaping. And I think that this is something that we can do within our science and within our scope of competence to then implement this strategy. All right, so we have a second ASR here. What does food chaining most align with in behavioral terms? Oh, they should be A, B, C, D. High P request sequence A, B is shaping, C is behavioral contrast, and D is extinction.
All righty, everybody. Thank you for voting so quickly. I will shut this down in a few seconds. Perfect. Thank you all. It looks like,
Perfect.
Wow, 6% said A and 94% said B.
Fantastic. And we will be talking about high P request sequence here in just a moment. So hold tight on that one. All right, but yes, the answer here is shaping. As we saw with what nutrition calls food chaining, we are essentially shaping across topographies and getting to that terminal goal of where we're hoping to get our client. All right, so that is just one suggestion from nutrition. Now I'm going to pivot over to occupational therapy, sequential oral sensory. First of all, I think that this is a really great option. It is backed by empirical evidence in the field of OT, but we'll talk about in a little bit how it might look a little bit different within our own science and within our own scope of competency. So sequential oral sensory is essentially defining food selective, in OT, they recommend the use of SOS, but it's essentially play-based approach to feeding, aims to address a variety of feeding dysfunction. And intervention is a progressive, hierarchical, graded approach that exposes the child to new tastes, textures, colors, foods, and liquids. Now, again, how OTs implement SOS is different and is absolutely in alignment with their area of expertise. And here's actually an example of a video. I can send this out or ask if VDS can send out this deck if you're interested. We're not going to go through this video right now just because we do have limited time, but this is a really great example of what it would look like to implement by an OT. Now, what I was interested in, because I'm like, wow, SOS, sequential oral sensory, this is essentially just incrementally taking closer steps to accepting food. So now we're kind of shaping within a topography because it's the same food item, but it might be looking a little bit different. We're making these systematic changes towards that terminal goal. But I was interested, okay, is there anything in our science within our journals that are in alignment with SOS? So I found one publication in JABA 2016. They did a modified SOS with addition to a DRA. However, there were also mixed reviews when I was looking at the literature specific to SOS and how it is positioned in occupational therapy. So be mindful of that. So there's not a ton of research on this in behavior analytic journals as a true SOS. But again, there are some variations that I will show you here in just a little bit. So let's get over to where all of our comfort is at, behavior analytic reinforcement-based procedures. So now we're in our science, right? We're in our literature. And what does this say about food programs? So let's talk a little bit about using shaping to increase food consumption There was an article published in 2017. They used differential reinforcement and shaping to increase food variety. Participants were introduced to new foods, again, on a hierarchical exposure. And I think this is so important. And in a couple slides, I'll show you how to systematically implement that. But this systematically increased the desired response with each food item. So the results were all participants accepted all foods, expanding upon from their baseline levels. So here's the differential reinforcement of alternative behavior as far as food programs go. This was published in 2015. There was a 12-step graduated exposure for food acceptance. So the child was led through this hierarchical and also parent training was implemented for generalization. Again, I think the parent training piece to this is so important, and we will talk about that at the end. But the cool thing is, after this 12-step graduated exposure to the different food items, after 9 months, participants' food repertoire increased from 4 to almost 50 items. So it was highly effective. And again, this is behavior analytic literature and how we can implement food programs in a reinforcement manner. Food refusal behavior decreased to rates of 0 during intervention as well, and also significantly decreased at home. So here's the systematic tracking sheet for implementing this within our own science. So you can see here, there are 12 steps, and we are starting with just tolerating food in the therapy room, like just have it in their environment. Then it might be closer to them and on the therapy table. And then it might be 1 foot away. Then they're gonna have to touch it and then throw it away, smell it, kiss it, lick it. So it's essentially just getting closer and closer to that acceptance to eventually get to a place where they're eating an entire piece. And then you can see here for this literature, the target food was carrots, cheese, cracker, and grapes. But what I like about this is it is so systematic, and it is essentially using shaping and DRA to accept food. But this also looks very similar to SOS and what we saw in occupational therapy. But again, this is presented in a way that's within our scope of competence as behavior analysts. So here's just a picture of a little cutie where her mom actually is a BCBA, and they did the modified SOS where they smelled it, kissed it, licked it, tasted it, ate it, and food acceptance increased for this little one as well. All right, let's talk a little bit about high probability request sequence. So essentially just using high P requests. Hopefully many of us know what this is, right? We're gonna have some easy to grab tasks or behaviors to then be able to give them that low P request that maybe is a little bit more challenging for them. So we can do this with food programs as well. So what's cool about high probability request sequence is it's non-aversive procedure for improving compliance, may decrease excessive slowness in responding in areas where there are high P request sequence may be effective following instructions, completing academic tasks, and food consumption. So this was an article published in 2012 in JABA. They studied how high P instructional sequence combined with low probability demand fade. The participants, there were 2 boys, history of food selectivity, and there was an absence of escape extinction in this intervention, and they really just used these reinforcement-based procedures, and it was effective in increasing food consumption for both participants. Another article published in JABA 2017, I believe, evaluated the effectiveness of using high P, using 3 presentations of preferred food on increasing acceptance. And the result of this was an acceptance of 3 new foods. Here's just an example of how it would look if you're implementing it, and also some language that I prefer to use when talking about food programs. So first of all, like it. Those are our neutral foods. These are the home runs. These are the ones that like, they're safe. We know they're going to accept it. In my house, they're the, what are the Hawaiian rolls? Those are like it, right? Those are home runs every time. Neutral food. Then we have the learning it. So of course we talk about target behaviors, target food, but I also like the language of learning it because we're learning and exposing ourselves to this food item. It could be aversive, but we're not going to label it or code it as aversive. It's just we're learning it. We're exploring it, right? And then we love it. This is our preferred reinforcer. And I also think it's important to note that when doing food programs, You don't always have to reinforce with an edible. I think this is something that many of us are like, oh, but it's food. Like, is this where we do it? But also that feels a little like, ooh, I'm thinking of my ethics right now. So when we talk about high P instructional sequence, or any time that we are implementing any type of reinforcement, it can literally be anything. It can be a preferred activity. It could be iPad time. It could be playing a game. It could even be broccoli. I'm not kidding when I say that my children, their preferred reinforcement is seaweed snacks. If you ever had little seaweed squares, and broccoli. And so that's what they would work for. Now, again, it doesn't look like a treat, but to them, that is a high preference. So I think it's so important to note that when we're talking about preferred reinforcement, it can be anything. And just because we're doing this within food programs doesn't mean it has to be candy or an edible, or, dividing a fruit snack up into fourths. All right, so let's talk a little bit about pre-MAC principle as well. So this is the first then approach, as many of us are familiar with this. First eat your carrot, then you can have your fruit snack. This is using the motivation of the client to move through mealtime. And there's studies that show that this is effective, where results are showing acceptance across 3 target foods, and dietary changes were maintained at 3-month follow-up. So I think that maintenance piece to this is also so important, that maintenance and that generalization, that many of these procedures that are being implemented are showing to sustain across time. All right, then we have our third ASR. When using pre-MAC principle with food programs, the reinforcer must be an edible. True or false?
Awesome. Go ahead and take some time to answer that, or not. You guys are voting so quickly. Wow. Okay. I'll shut this down in like 5 more seconds, just in case anybody is getting to it a little bit later. Awesome. Thank you all so much. Nice. Okay. Wow. 5% say true, 95% say false.
Fantastic. All right. So that is correct. Again, thinking of just whatever your client or even your own child would find reinforcing, you can use that in the food program. It does not have to be an edible. And again, reinforcers can be anything that they're motivated to access. All right, so this is the literature side of things. Are there any questions before we kind of pivot to the parent training piece to this training? Obviously, I love Buddy the Elf, so we had to show him some love today.
All right, everybody, go ahead, put your questions in the questions box. So far, I didn't see any when I was filtering through. I saw a lot of feedback from your earlier question. Oh, here we go. How would you adapt these for older clients?
Great question. Really, it's just you're doing it the same way. Everyone is motivated by someone. You're going to identify what is the baseline, which intervention package would make the most sense for this client, but then you'll just continue to modify it to be in alignment with where their preferences are. So I don't really necessarily, of course, my experience is with younger kids, but this absolutely can work with really any age group if you're trying to increase that acceptance of the food item.
Awesome. Alrighty, let's see. At what point do you recommend families seek food-specific services? For example, if the child does not chew and only swallows food, do you have recommendations on the type of service to ask for?
Yeah, so I would 100% before any before any food program to then refer out to a medical professional. This could be your general physician, it could be OT, this could be speech, someone who specializes in the mouth, in the tongue, in the swallowing, and just make sure that there's not anything physiologically happening or biologically concerning. And then from there, if they give a clean bill of health, all is good, then we can continue on with food programs, but you must refer out to a specialist that's within that scope of practice. So again, these strategies and suggestions are really if we know that it is not, their food selectivity is not causing, or is not being caused by a medical issue.
Awesome. Do you want to take a couple more questions? There's a lot piling in.
Oh, okay. Well, let's continue on. I don't know if we can continue because some of these questions might get answered as well as we get to this next phase, and then hold more questions then. Does that work?
Sure. Sounds good.
Okay. Perfect. All right. So let's talk a little bit about parent training. What do we share? Again, I know many of you on this call today are clinicians, and the goal with this piece is for you to have little nuggets of information that you can then implement and transfer to your families. Because again, I can't stress enough the importance that our clients not only need to be successful with this in the clinic, but they also need to be successful with this at home. So what can we do? How can we implement different strategies at home that feel easy? Like, I'm a parent. I literally have 2 children home with me right now for a snow day. And when I say the information that comes in, I'm like, okay, this feels like a lot. It's fine. But we need to be mindful and compassionate to our families that they have a lot of other things going on. So how can we support them to also support generalization, which is what is in best practice for our client, to make sure that some of these strategies are being implemented at home as well? So I'm sure you've heard, or maybe have even tried, parents that are like, oh, I just mix veggies and fruits and blend it in with a smoothie, or I just hide it in other foods, or I just wait it out. I think it's important that we are open and transparent with our clients and our children as we are trying to expand food items to them. Because oftentimes if the parent is hiding or sneaking vegetables, that could potentially increase picky eating. Because what happens if they're like, wow, I found an onion in my food and that's not what I want? Now that trust is broken down, and they are going to be even more selective of what they're eating, because now they're not trusting that whatever they're eating is what they think or intending it to be. So what do we do from here? So first of all, repeated food exposure. So this is from Journal of Nutrition Education, and the objective here is to have repeated exposure with different food types, and that will ultimately improve willingness to try, like, and consume healthy foods. The result of this study is children exhibited a greater consumption of different types of healthier foods at follow-up assessment. So we just want to expose them. It doesn't mean they have to eat everything, but we want them to be exposed to a lot of different options. Here's one example, one testimony of a little one that the mom just kept trying to give the exposure. I was like, hey, I think food exposure is really helpful for these clients. So she just continued to try to offer it. Of course, didn't force him to eat anything, but as they just continued to present it to this individual, that he started eating grapes and started eating, I think it was carrots maybe, I don't remember. But again, repeated taste exposure promotes food acceptance. Food preferences learned by tasting, and repeated tasting of foods helps to develop long-lasting habits. I believe the metric is at least 8 times that if there is some sort of exposure or an attempt, it could take up to that long for you to be like, oh, I do actually like this. Or I'm sure we all have experience as well where it's like, oh, I like a banana. And then tomorrow I'm like, I don't want bananas, even though I just bought a huge pile of it. But again, just being consistent with that food exposure is really helpful for those long-lasting habits. Availability and access. I mean, this is essentially just an environmental modification where you are just providing and exposing, again, that food exposure, different food items that are preferred just out and available to the clients and to your children. So are healthy food options readily available? Are they easy? Reducing that response effort to access that snack or that food item, that is what we want to have out, because anytime it takes a little bit too much time to prepare or to access or to consume a healthier food option, the likelihood is less, because it's like, okay, well, I'm just gonna actually grab this bag of chips because it's so easy. So instead, doing the food prep that makes sure that the healthier options are available. Now, this is something else that I try to also share when talking about food. There's not a good or a bad food. They're just food. Some are healthier, some do more for our bodies as far as what energy it can give us. But I'm also trying to share that language as well, that it's just food. It's not a good or a bad, it's food. But of course, we want the foods that are going to put more into our bodies instead of just completely deplete. Plant a garden. I love this one. Now, and this can even be in clinic as well, if you're in an environment that you would have space for a garden. But the objective here is increase knowledge about nutrition and health, introduce children to a variety of fruits and vegetables, explorative play and sensory learning, and also increase connection with natural environment. These are pictures from a friend of ours that they have an epic garden in their backyard. And there was one day I was picking up my kids and they were like, hey, Mom, come back here. These kids were chomping on fruits, vegetables, even edible flowers. They were so excited to share this experience with me. But also, if you have a client or your own child that would be interested in that, first of all, they're taking ownership in what they are growing, what they are tending to. And then they're also going to be organically more interested in those food items because they have helped nourish and grow it. I also understand not everyone has space for a full-on garden. So here are some alternative garden ideas and also some fun items to plant that kids most often find pretty interesting. So edible flowers, here are some options for that. Tomatoes, strawberries, which I always say taste like nature's candy. And the small alpine variety are the ones that are really small and sweet. Herbs as well. So anything that you can do to generate excitement over healthier food options would be fantastic. They eat more if they help. So all the time, I'm like, all right, kids, who wants to chop up the veggies? Who wants to chop up the fruit? Whatever it is. Here's a picture of this picture was taken years ago. Got kid knives and they just went for it. Did it look pretty? Sure did not at all. But they felt the ownership again and that autonomy that they helped create the meal that we were all going to sit down and eat together. Offering choice. So I find choice to be such an important component to really any intervention, but especially when it comes to food programs. So this may cause an experience of autonomy, which we want them to feel that, especially for something like eating or something that is a basic need. We want them to feel like they have autonomy in what they're putting in their own bodies. And then also facilitate greater overall intake of vegetables. And again, kind of circling back to that preferred item, that this item can be anything, highly preferred item, favorite activity, book, iPad time. Again, when we're reinforcing these behaviors, it can be anything. It does not have to be a sugary sweet candy or something that, maybe isn't as good for your body for long periods of time. It can literally be anything. Listen to the child. So if they say they are hungry, offer them a snack. We want them to start regulating their own mealtime and their own intake. And this is another great time to offer those choices. Would you rather have an apple or a banana? Or even like if it's PECS, giving them the choice, what snack do you want now? But just listening to them and then reinforcing when they are listening to their own bodies and be like, oh, I'm hungry. Hey, I like that you recognize that. Here's some food options or here's their choice. Again, we're just reinforcing those independent skills when it comes to eating. Sharing family meals. Studies show that if you have at least 3 meals per week, you're at a healthier weight and show a reduction of eating unhealthy foods. This is also a really great time to create some of these family interactions and connections. Now, of course, depending on the client and their level of vocal communication or just functional communication, it could be a great time to ask guided questions. I know at our table, we do sweet sour service. What was the best part? What was the worst part of your day? And how did you help someone? This is my family's favorite time. My kids all the time are like, what's your sweet sour service? But it just helps to, first of all, share that family meal, have some connection, but it also helps to model mealtime behaviors. So research also suggests that parents model healthy eating habits, limited consumption of snacking or daily consumption of fruits and vegetables. So when parents model healthy eating, children are more likely to engage and also accept those healthy food varieties. Now, here's an example of my little one. She was 2 maybe here, and we eat a lot of spinach in my house. And she just, because she saw her daddy doing it, she just started eating spinach from the bag. But again, this was modeled mealtime behavior for her. Also, one thing I always suggest, because I get it, okay? I understand that there are some clients, the selective eating is very intense where it makes it more challenging. Any type of meal is stressful. I always suggest to cook one meal. Whatever you're eating, serve that to your children or your clients. But also it might look a little different. So I might deconstruct what I have just given to my family. But I also make sure that there is always a home run. There's always something, that neutral food there like it, that is always on their plate, because I want them to have an option to build that confidence as they sit down and eat, and they don't just see a plate full of food and they're like, this all looks like crap. No, we want them to at least dive in deep and build that momentum, and then they might start exploring or may even just have that exposure, and that's fine if all they're doing that day is touching it. But we want them to still be able to eat and feel like they are completing that behavior, that preferred behavior at the dinner table. Be creative. I know it's like, listen, we don't have time for this. there are some ways that you can have fun shapes, fun creations with the food items, but something else that we do a lot that takes no prep at all is just playing games at the table with your food. I know it's like, don't play with your food. Well, maybe you could if it's creative and fun. So one thing that we would say is like, I'm going to eat this broccoli and it's going to give me an animal sound, and everyone else at the table has to guess what animal I'm pretending to be. But my magical broccoli or whatever it was, that is what gave me that animal sound. So just having fun with it and engaging with that type of play to help, again, familiarize themselves with other foods and to kind of take away some of the initial stigma of like, oh, but this is broccoli and this is not the vibe. But no, let's just have fun with it. Let's play with it. If you just touch it, fantastic. What special power did that give you? And then grocery shopping. I can't tell you how many new fruits and vegetables your girl here has tried because these children were like, we want to try this. Dragon fruit. Okay, cool. It looks a little funky, but here we are. And now we get it all the time. But it's because we go to the store and we just let them choose. What do you want to try today? And then we have an ASR here. So which strategy is not considered best practice tips for parents to increase food acceptance? I think we're doing okay on time. Hopefully there'll be a lot of time at the end for questions.
Awesome, and thank you all for voting. Alrighty, I will shut this down in just a few seconds. Perfect. Awesome, it looks like 9% say grocery shop together, 3% said model mealtime behavior, 85% said make several food options during one meal, and 4% said offer choice.
Fantastic. All right, so the answer here is make several food options during one meal. This is one tip that is not suggested. And also it's just a lot of response effort for the parents as well. But of course, there are so many other things that we can do or suggest to our families to help support food acceptance and even just food exposure. All right, so it's something else to consider. Once again, picky eating is on a continuum, but also so is success. And I like to think that picky eaters or selective eaters are just adventurous eaters in training. They are figuring out if they want to like it, they're learning to like it. And so that is what I have. I know there are some questions. Hopefully we can get through them all. But again, I really appreciate you all being here and to talk about this topic that I know many of us are impacted by with our clients.
Alrighty, so as they flow in, let me see. Is there an ideal environment for food programming? Should the child be able to sit at the table for a couple of minutes, or is this something to worry about later on?
I think it first of all depends on the safety concern. Is this something where we are worried if they're just laying down that they could potentially choke? I would first rule that out. But if that is not a concern, I would meet them where they're most comfortable. Maybe it's sitting in a beanbag chair. Maybe it's in the car, who knows where, whatever they feel comfortable with, because then we can eventually shape them into an environment that is more preferred or more traditional. But yeah, I would meet them where they're at.
Alrighty. What would you do with a child that is mistrustful already due to the parent hiding one food inside of another?
I would just I can't even talk. Lead with consistency. Be very transparent. Be very open. Let them involved in some of the choices and even some of the food prep, because if they're seeing how it's coming together, that will kind of break down some of that trust, or not break down, build it up, I guess, and allow them to understand exactly what they're eating. So just consistency with that, open transparency. It's going to take some time, but hopefully with repeated exposure, consistency, allowing them to help with that prep, that will help them overcome that barrier.
Perfect. Okay, so what is a food tray called and how is it used?
What do you mean a food tray?
What is that food tray called? I think you might have used
Okay, so actually this is the product I invented and it was on Amazon, but after 2020, we did not do another production run. But a lot of my examples and testimonies were stemmed from that work. So that is my own product.
Ooh, all right. Lots of questions building in here. Is there a minimal number of foods that should be considered a red flag, or would it depend more on what foods the child is accepting before being concerned or needing to consult another professional?
Yeah, so as we mentioned at the very beginning, there's not a standard characteristic or metric that says, okay, now you are selective eating. We have to look at it with the whole picture and understand, okay, is this impairing their development? Are they not getting all the nutrients that they need? Now, I would definitely focus on, well, what foods do they eat, and then continue to expand from there. But it's hard to say that there's just a simple, here's the metric, and this is yes or no, because again, it is on a continuum. And there's so many other variables to consider as far as development goes. But again, that's why we're reaching out to medical professionals at first to understand if this is a potential concern.
Alrighty. Any suggestions on working on this with children with severe OCD towards new items in the environment?
Great question. The SOS would probably, or the modified SOS would probably be the best route for that. Of course, I can't make that conclusive because I don't know the case or the client. But I think that is such a gentle way of introducing new foods with anyone, because we are really going slow and we are making sure that we're mindful of the client's level of acceptance.
What are your thoughts on meal replacement type drinks like Pediasure while working on expanding food selectivity?
Okay, so this is where we go from, okay, we need to make sure our clients are eating and they're getting the nutrients. As long as you are also actively trying and working towards some of those like whole foods, I think a meal replacement is great as we're kind of in that that phase of expanding and exposure and trying to get them to accept new foods, because we need them to be healthy. Just making sure that we got it from both ends.
Alrighty. Let's see. What about children with food selectivity and on ADHD meds that suppress appetite?
That is tricky. Again, that would be more of a medical concern and something that maybe you could talk to your medical professional about, because if they're not hungry, it's hard to then motivate them to try something new. So that is where you could work with the medical professional and what's the best way to overcome that, since it is a side effect from medication.
Alrighty, let's see. How do you recommend introducing one food at a time for 8 times before introducing a new item?
It doesn't have to be that structured and like I'm only going to expose them to 8 carrots 8 times. I would definitely, if this is a part of a greater food program, I would definitely focus on one food at a time. But if something is organically or naturally coming into their environment because it was presented to them, I wouldn't say, oh no, we can't do that, right? We want this to be sustainable for the families, for the clinicians, for the child. We want it to make sense for them. So yes, as far as a structured food program, one food at a time, but if they are exposed to other foods, that's fine. Just maybe you aren't necessarily tracking that.
Alrighty. So what do you suggest for low-income families or single parents who only eat cereal or frozen meals for dinner and can't afford to buy a ton of groceries that may or may not be eaten?
Yeah, that one is tricky. But that's where, like, if they have an option to grow a garden, because seeds are what, 30 cents? I don't know actually how much seeds are, but that could be a more sustainable and more costly way to expose individuals to different healthier food options like fruits and vegetables, or to seek support to see if they can have additional funding. That is a tricky one, and one I'm not at all an expert in, but I would suggest maybe trying to grow some of those foods.
Alrighty. Any advice for food rituals? For example, only drinking out of a specific cup, eating with a specific utensil, in addition to selectivity?
Yeah, so kind of the example I use with the chicken nuggets, again, meeting them where they're at and slowly, incrementally making changes to kind of steer away from that rigidity.
Okay.
So,
So when introducing new food, how should food be prepared or presented?
small amounts. Like it should be the teeniest bit because we don't want to overwhelm them with a huge scoop of something new. So it might be one teeny tiny piece of broccoli that we're just exposing them to. Let's touch it, let's play with it, let's maybe put it to our mouth, smell it, whatever. I always suggest when you're starting out to have a very small amount. And then again, pair it with foods that you know that they'll take or they'll eat.
Alrighty. Let's just make sure this. Do you believe in any food is better than no food?
I do, for sure. Yes, because of course we need food to survive, right? That's first and foremost. It's when we then start having some acceptance of food and we need to expand that repertoire. That's where some of these reinforcement-based procedures can be implemented.
Alrighty. What would we suggest parents schedule an appointment for? Of course, interested in ruling out medical concerns that could relate to food selectivity, but if there are no muscle or motor issues that have been identified, what else would the medical providers be looking for?
Really a big part of that is the muscular and is your tongue working well to swallow foods? So it was really be focusing on that, but also just the medical professional may have other suggestions or other specialists that they could refer you to. But it's really just making sure that the physiological or the biological functions in your mouth are able to safely consume food.
Alrighty. What advice would you give for a client that typically eats well but goes on hunger strikes and then suddenly stops eating for several days?
I would first ask if they understand the function of it, like what warrants that type of response, and trying to better understand if there is some sort of antecedent that then leads them to that, and then working backwards from there.
How often would you do a food chain?
It's so hard to have a metric with that because, again, the progress of them going to that terminal food item could take a very long time. It could also be very quick. So there's not just one simple answer to be like 3 weeks. Again, you're just continuing to work with the client. And then as you have, maybe even 80% criterion that they're accepting it across however many days, if they're accepting that, then you can move on to the next. But you could just treat it like any other intervention as far as shaping goes or chaining.
Alrighty. Let's get down to the bottom over here. How would you approach a child eating a particular food type for several days and then no longer eat the food? It has been a source of frustration for the family.
For sure. At that point, then, because even we as adults, I know I eat foods and then after a while I'm like, oh, I can't even look at this anymore. Sweet potatoes for me right now. That is a very typical response. And so at that point, I would probably just try to expose a different type of food. And just, again, it's not, selective eating is on a continuum, and so is success, as I just mentioned. We're going to take 5 steps forward, 2 steps back, and just trust the process that this is a part of the progression for food acceptance.
Alrighty, let's take one more. Any suggestions for kids who are hungry all the time or eat way too fast?
Okay, so that's more of like a nutrition thing where you need to focus on the types of foods that you're giving them that will last longer, but also creating a schedule if that works for that client. Because if you are eating more consistently and having bigger meals, then that might sustain longer. So I definitely think a schedule for someone who's just constantly wanting to eat could be a great preference or a great suggestion there. But again, I don't know the case. This is just a general suggestion, but I think schedules are great.
All righty. Well, thank you so much, Anissa, and thank you everybody for joining us today. Go ahead and go buy news. And I will be analyzing all the data. You'll get instructions to access your CE certificates tomorrow by lunchtime. The certificate that you will receive in a few hours is a certificate of attendance. Just a general certificate of attendance, completely free of charge for you. So please just keep that in mind. It will have no BACB information on there. It will just be a certificate. We don't send out your CE certificates. You have to access them yourself. So just keep that in mind.